Well, thank you very much for the invitation to participate in this series of talks. It's been a great series of talks. I've seen some of them, and I think it's a fantastic thing that you've organized. Yeah, so my talk today is going to be presenting some of our recent studies looking at nutritional interventions in breast cancer. So if there's one take-home message I want you to get today, it is when you eat matters as much as what you eat. For many years, we focused on diet, various ways to combat obesity. But these days, there's increasing evidence that it's not just what you eat, but it's when you consume the calories that's important. So we know that physiology follows circadian rhythms. And this is a figure from a review written by a colleague, Ruth Patterson. And there's a human wake sleep cycle, and we know that various physiological processes differ at different times of the day. For instance, let me get the laser pointer. The risk of having a myocardial infarct is greatest in the late morning. Your coordination and muscular strength is actually best in late afternoon. We know that your body temperature is lowest sort of in the end of the sleep phase. So there are all of these circadian processes that are going on. And this also applies to metabolism as well. Most calories are consumed during the wake phase. So your liver is making glycogen, the pancreas is secreting insulin, you have lipogenesis in the fat, your muscle is using calories to do work. And then, in contrast, during the sleep phase, the liver is gluconeogenic, you're producing glucose, glucagon secretion goes up, catabolism goes up. So there are these rhythms, circadian rhythms in metabolism that mirror a lot of things that are going on in the body. So how are these rhythms coordinated? So we know that there is a central clock in the suprachiasmatic nucleus that's regulated by the light cycle. So this has been well established, and it makes sense that this is going to respond to light. But there are also clocks in just about every other tissue you look at in the body. And these clocks don't respond to light. There's no light input to these clocks. There are some cues coming from the central nervous system to the tissues. But it seems that a lot of these clocks actually respond to different cues. So the liver has a very strong nutritional response. So the clock in the liver actually seems to be driven more by nutrition rather than by any day-night cycles. So that's fine if you've got normal nutritional cycles. The problem is that currently we are eating pretty much the whole day. So this is some data from a paper that Sachin Panda published a few years ago. So they developed a small cell phone app that allowed people to track when they ate. So each circle represents a different individual, and each dot within the circle represents an instance where they consume something. And this is cumulative over many days. And what you notice is that there's really only a period of maybe 6 to 7 hours here where consumption goes down. The rest of the time, we are eating pretty much all day. So, up to 18 hours a day, we are consuming. So this is a problem because this disrupts the clock, because the clock likes to see a 12-hour cycle. So the talk outline, basically, I'm going to go through, obesity, diabetes, and cancer risk, have a few slides on that. You're probably all aware of this data, and you've probably seen it in other talks too. And then I'm going to talk about some of our studies of circadian synchronized feeding in preclinical models in mice of obesity-driven breast cancer. And then at the end of the talk, I'm going to talk about whether this is actually applicable to humans and whether this might actually be a good intervention. So I was asked to provide a little background. So this is a little personal bio. I got my bachelor's and master's at Cambridge in the UK, and then went across to America to get my PhD at Stanford University, and then decided to come back across the Atlantic to France to do a postdoctoral fellowship in Strasbourg. and then went back the other way across the Atlantic to San Diego, where I've been on the faculty since 1989 now. So we've had an interest in insulin and IGF-1 receptor signaling for many years. Back in the middle to late 90s, we purified receptors from fresh biopsies from breast cancer patients, and showed that actually the receptors, it was known that they were overexpressed, but what we found was that the kinase activity was hyperactivated. And so that was a novel finding, that this pathway is turned on in breast cancer. And more recently, we've been looking at the effects of obesity on cancer growth. And just as a personal note, I've been living here in Southern California for 30 years, but I haven't taken up surfing yet. So not everyone in Southern California is a surfer. Okay, so the prevalence of obesity. So you've probably seen maps like this. This is from the CDC and shows the prevalence of obesity in the US in 2019. And you can see that there are many states here in the dark red that have obesity rates over 35% of the population. If you include people who are overweight, so they've got a BMI of 25 to 30, it's about an equivalent number of people. So overall, people that are overweight or obese, it's 2/3 of the population. So this is a significant health problem. There's also, unfortunately, racial disparities. So this shows the data for non-Hispanic whites versus Hispanics versus African Americans. And you see in these other communities that the obesity rates are much, much higher. And so this tends to be in the lower socioeconomic classes. And so we have quite a heavy burden here of racial disparity in the obesity epidemic. So diabetes is a smaller number of people, but this is a figure taken from the International Diabetes Federation, and it shows the worldwide occurrence of diabetes. And most of this, 90–95% are probably type 2 diabetics. There's a small number of type 1. But it shows the current number in 2019 and the projections of what's going to happen over the next few years. So in North America, currently there's just under 50 million people, and that's projected to go up to over 60 million in 2045. If you look at the Western Pacific here in purple, currently there's 160 million people that are diabetic, and that's projected to go over 200 million. So this is going to be a huge health problem in the future. And this just shows the people that have diabetes. You also have to think, well, there's going to be another significant population who are pre-diabetic, who are obese or overweight, and that are probably going to eventually progress to diabetes. So these numbers really just show the tip of the iceberg of this sort of the obesity diabetes problem. So you saw a diagram similar to this if you saw Signe Borchgrev's talk the other day, and this shows the cancers that are associated with obesity and physical activity, and it's taken from the American Association for Cancer Research. So there are a number of cancers here that are common to men and women that are linked with obesity, and some with physical activity and some with both. So liver cancer is a cancer that shows both an obesity effect and a physical activity effect. So many cancers here seem to be affected by the nutritional environment. And what we're going to talk about today in my talk is post-menopausal breast cancer. So what's the best evidence that really obesity is doing something? Most of these studies, most of that data is associations from epidemiological studies. The best way to really test whether obesity is causing something is if we can remove the obesity. And you can do that with nutrition and diets and exercise. But a study that I like is if you use bariatric surgery, that's probably the quickest way to get rid of obesity. And this is a nice paper from Dan Schauer, who looked at the effect of bariatric surgery on cancer risk. And so in the top left here, this shows all cancers. So there is a significant effect of bariatric surgery to decrease all cancer risk. If you look at those obesity-associated cancers, again, you see this protection following bariatric surgery. If you look at the non-obesity-associated cancers, these two lines overlap. So this is only the obesity-associated cancers that show this effect with bariatric surgery. So this is pretty good evidence that if you get rid of the obesity, you can improve, cancer risks. And if you look at the breakdown of what these different cancers are, things like this is the overall risk, reduction in risk, a reduction of 40% in the hazard ratio. You see this in colorectal, endometrial. You see this in postmenopausal breast, pancreas. Liver doesn't quite make significance here, but it's almost significant. So many of these cancers, the risk of these cancers goes down with bariatric surgery. So that's pretty good evidence that obesity is having, a direct effect. This just shows the breast cancer data specifically. And I want to point out that in premenopausal breast cancer, bariatric surgery is associated with a reduced risk of the ER-negative breast cancers, whereas in postmenopausal, it's actually associated with the ER-positive breast cancer risk. So both pre and postmenopausal breast cancer seem to have an obesity component, although we're more used to talking about the postmenopausal case. So what are the potential mechanisms that link obesity and diabetes and breast cancer? And this is a nice figure that I took from one of Emily Gallagher's reviews that she wrote with Derek Leroyce. And Derek and Emily have worked for many years on the effects of insulin on breast cancer growth in mice and humans. And so this basically shows the tumor cell, and then we have obesity or type 2 diabetes. So in obesity, we know that there's increased inflammation, there's increased macrophage infiltration, there's an M2 to M1 conversion, so they're more pro-inflammatory. There is expression of aromatase in some of the adipose tissue, so you can get peripheral conversion to increase estrogen levels. We have cytokines and adipokines. We also have insulin resistance that's associated with obesity that may actually be a component of this inflammatory response. So the hyperinsulinemia that goes along with the obese state, and that can have direct effects through the insulin receptor, or can have indirect effects through changes in the IGF binding proteins that can change the IGF-1 signal in the tumor cell. And then there are other sort of indirect effects maybe through effects on the microbiota. So this is a nice sort of summary of the potential mechanisms that could be mediating this crosstalk between obesity and breast cancer. And in our studies, we seem to think that it's mainly the hyperinsulinemia that's driving this. We've looked at some of the others, and we don't see so much evidence for those. But in our hands, it seems to be the hyperinsulinemia that's the real culprit. So how do we treat obesity? So what are the current strategies? Diet, caloric restriction, different diets, exercise, bariatric surgery, and a small number of drugs that target obesity. And while these will work in the short term, in the long term, none of these are really effective. Even bariatric surgery. Certainly the experience at UCSD is that the people that come in and have bariatric surgery, after 5 to 10 years, they've pretty much put most of that weight back on again, which is sort of quite surprising because this was thought to be an approach that would actually provide long-lasting benefits. But they're not effective in the long term. So, is there another solution? So I want to talk about this sort of synchronized eating. If we synchronize your eating patterns to circadian rhythms, is that beneficial? And this is a figure that was adapted from one of Sachin Panda's reviews. And so if you allow a mouse to have a sort of a Western diet, it will eat pretty much the whole 24 hours. It'll nibble, it'll graze on the food the whole time. And what happens is the circadian rhythms get suppressed. If you measure the rhythms in the liver and elsewhere, these most of the genes, the metabolic genes that show these rhythms, the amplitude goes down and there's some phase shifting as well. So the thought is, if you just restrict when they eat the food to when they would naturally be eating, which for a mouse is in the dark because they're nocturnal, maybe you can reinforce those rhythms and perhaps correct the metabolic problems. So we've done this in a post-menopausal obesity model. A number of other labs, Sachin Panda, Joe Bass, Paolo Sassoni Corsi, many other labs have done similar studies in male and female mice. So we're not the only people working in this area, but I just wanted to show you the effects of this timed feeding on the obesity phenotype. So in this case, we make the mice obese first by giving them a high-fat diet. They eat a lot of it and they get fat. So we take a cutoff as 40 grams as the cutoff of being obese. Then we randomize them to just continued ad libitum access. They can eat whenever they want, or the timed access. And these mice eat the same amount of calories. So it doesn't change the caloric intake. In the timed feeding group, it stabilizes their obesity. There's a small decrease to begin with, and this is when they're adjusting to the new timing of when they get the food. But once they figure out that they only get the food in a short period, they start eating during that period, and it maintains their obesity. The ad libitum group, in contrast, continue to get fatter and fatter. This just shows the food intake from some clam studies, and you can see in the TRF group, obviously, as soon as food's available, they eat a lot, and then they have that sustained eating throughout the 8 hours they have food available. Whereas the ad libitum group in orange kind of graze throughout the day. Normal chow, there is more of a circadian rhythm. They do eat more in the dark than they do in the night. And that's kind of suppressed in the high-fat diet group. If you look at fasting glucoses, there's an elevation in the ad libitum group, and that's corrected by the TRF. If you look at fasting insulin levels, those are very much elevated in the obese ad libitum group, and they are corrected with the time-restricted feeding, even though they're still on the high-fat diet. And if we look at glucose metabolism, so these are glucose tolerance tests over time. So at 3 weeks, we really don't see much of an effect. There's starting to get a little separation here between the ad libitum and TRF. Obviously, the normal chow are very sensitive, and the other two groups show glucose intolerance. By 6 weeks, we actually have much better separation. So now we have significant difference between the ad libitum and the TRF. And by 8 weeks, the ad libitum group is still insulin resistant and glucose intolerant, but the time restricted feeding looks exactly like the normal chow lean control, even though they're still eating the high fat diet and they're still obese. So it does correct metabolism. Does this work in humans? So there have been some small studies that have looked at this in different groups, and they all show some positive effects. The one that I like the best that I want to talk about is one actually from Courtney Peterson's group. So this was a very nicely designed study. It was very small. It was in 8 pre-diabetic men. It was a 5-week randomized crossover design with a 7-week washout period between. And it was calorie matched. So everyone got exactly the same number of calories. The meals were prepared. So they all ate the same thing. The only difference was whether they ate it over a 12-hour period or a 6-hour period in the morning. So they call this early eating, so early time restricted. And then they were given enough calories to maintain weight. So this was not a diet. There was no weight loss here. And then they did metabolic assessments by glucose and insulin response during a GTT. And so what they found was that the postprandial insulin was down, the insulin sensitivity was up, beta cell function was up, blood pressure was reduced, oxidative stress was reduced. And interestingly, appetite in the evening was reduced in the group that had this early consumption of calories. So later on, here in the evening, they were less hungry. There was an interesting observation, actually fasting triglycerides went up, but that was probably because they did this assessment in the morning. And so this group had been fasted for 18 hours, whereas this group had been fasted for 12 hours. So that may account for the difference in the triglyceride. But so this is a nice controlled study that showed that this approach of synchronizing feeding to your circadian rhythms could actually work in humans. All right, so then we wanted to test whether this would affect cancer growth. So we used our model of this timed feeding, either ad libitum or time restricted, in breast cancer models, and we were hoping that because we correct metabolism here, that the obesity effect to accelerate tumor growth would be eliminated. So this is the design. So we actually used 2 post-menopausal models. One was the overreactomized mouse, female mouse. Take away the ovaries, so that's complete loss of ovarian hormones. The other one is a chemically induced model. So you treat the mice with this compound 4-vinyl cyclohexene diapoxide, and this is toxic to the primordial follicles. So then you treat them over a series of days, and then you wait. And the follicles get depleted. And so after about 100 days or so, you have no primordial or primary follicles left. And so this is more like a natural menopause. And then this is the feeding strategy. We had 3 groups: normal chow all the time, the high-fat diet to let them get obese, and then continued high-fat diet, the high-fat diet to let them get obese, and then switch to the timed feeding. And then 3 weeks after we switched to the timed feeding, we did an injection of tumor cells. And we used 2 different breast cancer cells, the PY230, which form luminal A type breast cancers, they're ER, PR positive, and HER2 negative. And the other one was an EO771, which was a more aggressive cancer, more of a luminal B characteristic. It's ER negative, it's still ER positive, and it's ERB2 positive. So what did we find? We found that in the OVX model with the PY230, the ad libitum high-fat diet accelerates tumor growth. So this had been known before. And what we found is the time-restricted access completely eliminates this obesity effect, and they look like the lean animals. It also works in the chemically induced menopause model. We see exactly the same thing. In the, excuse me, in the more aggressive EO771 cells, again, we see this obesity effect or accelerate tumor growth, and that's eliminated again. So in these models, it works. These are, orthotopic injection models where we're introducing cancer cells into the mammary fat pad. So we also looked at a spontaneous model, and that's the PYMT mice that express the polyoma middle T under the MMTV promoter. So it's expressed in the mammary epithelial cells, and we overreactimize the mice at an early age and then look at when they get tumors. So in the ad libitum group, they would start to get tumors after about 13 weeks. And by 17 weeks, they all have tumors. In the time-restricted feeding group, even though they're on the same diet, we get a delay of about 4 weeks in the appearance of the tumor. So there's a delay in the initiation of the tumors. And if we look at the tumor growth, you see that the growth of these tumors is suppressed too. So in a spontaneous model, it's an oncogene-driven one, but it is a spontaneous model. We see this inhibition. So it did seem to work. So then what we did is, we wanted to check whether this was insulin that was causing this. So we did a study where we had the same paradigm with the 3 groups, but then we had a 4th group that was the time-restricted feeding, but we implanted insulin-releasing osmotic pumps. So this restored the insulin levels to the values seen in the ad libitum group. And we were hoping that this would overcome the TRF. And indeed, that's what we see when we looked at the tumor volume at the end of the study. The tumors were much larger in the ad libitum group. It was reduced in the TRF that looked like the normal chow. And then we implant the insulin pumps and they go back to looking like the ad libitum. So simply increasing the insulin levels can overcome the effect of this synchronized feeding. If we take the opposite approach, we took the high-fat diet ad libitum group and then fed them diazoxide. So this will suppress insulin secretion, and we gave them a concentration that would not make the mice hypoglycemic. There was a small decrease in their glucose levels, but they were still in the normal glycemic range. And what we see here is with the diazoxide, it will inhibit the tumor growth here. So simply by reducing insulin levels using a pharmacological agent, we can inhibit the tumor growth. So circadian rhythms, this is a transcriptional mechanism. A series of transcription factors that drive these clocks. So the positive arm is driven by clock and BMAL, which induce expression of the genes cry and purr, the period and the cryptochrome genes. These are then synthesized in the cytoplasm, they get phosphorylated, they get imported into the nucleus, and these act as negative repressors of clock and BMAL-driven transcription. So this is the sort of the essential component of the clock. There's a positive arm and there's a negative arm. And this is what underlies all of the circadian rhythms that are seen certainly in the light-driven cycles, and also most of the nutrition-driven cycles as well. So this is a negative feedback loop. So something must be keeping this going, because typically if you have a negative feedback loop like this, eventually this will come to a steady state. So something must be keeping these oscillations going. And we know that in the brain, that is the light cycles, and in the liver and other tissues, it's the nutritional cycles. So we looked at the expression of these genes in different tissues. So this is in liver, mammary fat pad, and in the tumor. And this is a whole panel of these clock genes. And you see in the liver, we get these nice oscillations. This was measured over 24 hours, but we plotted it over 48 just so that you can see the rhythms better. And you see there, there are distinct phases. That BMAL tends to go up during the dark phase. And this is when the PER1 and PER2 are down. So BMAL and PER tend to be in antiphase. There's the reverbs, which is another family, which tend to go up in the light phase. So you see similar patterns in the mammary fat pad. It has clocks too, and you see the similar phase relationship here. But if you look at the tumor, there are oscillations in these genes, but we don't see the same phase relationship. We see a lot of these genes tend to peak during the light phase. There's a couple here that are going up during the dark phase, but there seems to be some kind of synchronization of these peaks that you don't see in the other tissues where these phases are much more spread out. So there is an oscillator in the tumor, but it doesn't seem to be working quite the same way as it is in the normal tissues. So we also looked at the effect of diets on these cycles. So this is the mammary fat pad, and it just shows 3 of the genes. So it shows BMAL, PER1, and CRY1. So in the normal chow, which is in this light blue, you see these nice oscillations in the mammary fat pad. If you put them on the high-fat diet ad libitum, it actually suppresses those. There are no significant oscillations here. And then you put them on the TRF, and it restores these oscillations again. If you look at PER1, PER1 is not cyclic in the normal chow, nor on the high-fat diet, but becomes cyclic with the timed feeding. And then CRY1 seems to be cyclic under all conditions, although the amplitude of the oscillations is a little reduced on the ad libitum diet. So the TRF is able to, reinforce and actually restore some of these rhythms that are lost in the obese high-fat diet mice. If you look at the tumor, it's a little different. So in the tumor, there is this oscillation BMAL in the normal chow. When you put the mice on a high-fat diet, the overall expression of all of these clock genes goes up. We still maintain some oscillations, but there's a slight phase shift here. There's a phase delay of about 4 hours or so. That is corrected by the TRF. For PER1, there is an oscillation here in normal chow. There's this increase in expression on the high-fat diet and an elimination of the oscillation, and then that's restored by the TRF. The CRY1 gene, in contrast, is acyclic under all conditions, and we never see any oscillations of that in the tumor. So the diet and the TRF is able to restore some of these rhythms, but what we see in a tumor is different from what we see in the normal tissues. And so one of the remaining questions is how does the clock in the tumor work? Because it doesn't seem to be working in quite the same manner as it is in the normal tissue. So that was, the mouse studies. And I just at the end here, I want to talk about, is this relevant for humans? I mean, can we do this in humans? Is this going to work? So in humans, the equivalent would be a prolonged nightly fast, right? Because we eat during the day and we shouldn't be eating at night. And when through evolution, we didn't eat at night. So if we put people on a prolonged nightly fasting regimen, will it improve their metabolism or reduce their cancer risk? So there are no studies where anyone has done this, prospectively. There are studies, epidemiological studies where you can get a hint that this might be the case. So one of them is the Women's Healthy Eating and Living study that was done at UCSD under John Pierce a number of years ago. And so a graduate student, Catherine Marinak, who was working with Ruth Patterson, went back and looked at the data and looked at the data that they had collected from, it was over 2,000 breast cancer survivors. And they had complete data as to what their feeding patterns were and all these kind of things. And they found that for the women who fasted for less than 13 hours a night, they had an elevated risk of recurrence, okay, compared to the ones that had a longer fasting period at night. So that's suggestive that, yes, if you have a longer period of fasting, you're going to reduce your risk of recurrence in this case. So there was another study in 900 patients in China, 900 people with incident breast cancer versus 900 controls, and they looked at eating patterns. So eating after 10 p.m. was significantly associated with increased risk of breast cancer. The odds ratio is about 1.5. And the strongest association with people who had an over 20-year history of eating late at night. And there, the odds ratio went up to 2.28. So again, it suggests that eating late at night is bad. And lastly, there was a case control study in Spain of 1,200 breast cancer and 600 prostate cancer. And normal women. And they found that a longer interval between the last meal and sleep, in other words, eating earlier in the evening, was associated with a lower cancer risk for both prostate and breast. And there was similar protection if the meal was eaten before 9 versus after 10. Because in Spain, obviously, people like to eat late, and people very often eat the last meal of the day at 10 p.m. So that is actually very bad and will increase your cancer risk. And if you have your meal earlier in the evening, you can reduce the risk of both of these cancers. So it suggests that actually this probably will work in humans, although no one has actually done the random controlled trial to test this. We are hoping to actually do some of those trials if we can get the funding to do that. But it suggests that this should work in humans as well. All right, so just a summary, we showed that the time-restricted feeding improves metabolism in the obese mice and inhibits tumor growth in various models of obesity-driven breast cancer. We've also done this in models of NASH-driven liver cancer, and it does exactly the same thing. We can inhibit liver cancer growth in mice on a NASH diet. And then there's epidemiological evidence that suggests that it will have a similar beneficial effect in humans. But we need to do the large-scale controlled trials. So with that, I'll just go to my acknowledgements. So this is my lab here. Most of the mouse work was done by postdoc Manasi Das. She's here. Really a phenomenal job to do all this timed feeding in these multiple animal models. And we have various collaborators. Dorothy and Ruth, we've collaborated for many years on studies of energetics in cancer. Dorothy Sears is an expert on circadian rhythms. Leslie Ellis is an expert on these mouse models. And Isabel Newton's been helping us with the liver cancer model. And then this is the funding that supported it. And again, I'd like to thank the Danish Diabetes Academy for the opportunity to talk to you today. Okay, thanks.
Thank you very much, Professor Webster, for this fantastic talk. It was truly interesting. And hello, everyone. Thank you for tuning in. I'm Lucas Stülow. I'm Associate Professor at University of Copenhagen, and I'm your chair. And being the chair is good because then I get to ask the first question. And I would really like to do that. So, and while I do that, you can either put your question in the chat and I can read it out loud, or you can just raise your hand and I can unmute yourself and you can ask the question yourself. But I was wondering if there's any evidence that this time-restricted feeding in mice alters activity or increases activity levels, and also if there's any evidence from humans that it might influence experienced fatigue or experienced energy levels?
In the mice, we don't see much difference in the overall physical activity. There's a difference in when it occurs, because with the timed feeding, they tend to, during the day when they're fasting, they tend to just kind of sleep. But in studies that have been done of this timed feeding in humans, there are actually reports that people feel like they have more energy, their sleep patterns are better, they sleep better. So I think doing this sort of synchronized feeding regimen will probably help with people's physical activity because they'll feel like they have more energy.
Yeah, and it would also be important in, for example, cancers that are often associated with reduced energy levels as well. So yeah, but thank you very much. And then I think Professor Renehan has a question.
Hi, Nick. Nice to meet you. Andrew Renehan at the University of Manchester.
Yeah, nice to meet you too.
There's a huge volume of epidemiological evidence linking night shift working with cancer risk, not least breast cancer risk. And there's a variety of hypotheses put forward about melatonin, etc., and reduced lighting. I've always been concerned that these associations are confounded by obesity. Many of these night shifters do it for years, particularly in the health the health sector, and they become quite obese. Just wonder what your thoughts are on that area.
Yeah, you're right. I mean, and the night shift workers, they do have increased incidence of obesity and diabetes, and they have metabolic problems. So that is going to be underlying probably any of their cancer risk. So if you look at when the food is consumed, there are various studies of consuming food out of phase with your normal rhythms, right? And so like with Ramadan fasting, or studies have been done in mice and rats, sort of in various jet lag kind of paradigms. If you provide the food not in the correct phase with the circadian rhythms, there are some beneficial effects, but you don't correct the metabolism. So there was the study in rats where they did the feeding in phase and out of phase. And when they did it out of phase, the hyperinsulinemia persisted. Whereas when they were feeding in phase, it went away. So, when you eat is important. And, so that may, underlie some of this too. It's not just that you are eating in a short period and that period can be any time. It has to be, synchronized with your circadian rhythms.
Thank you. And then we have a question from Dr. Emily Gallagher.
Hey, how are you?
Hello, Emily. How are you?
Hey, Emily,
Good.
how are you? Good to see you again.
Good. You too.
I used one of your figures from your review.
I saw that. Thank you. So I always wonder with these dietary interventions, when we treat diabetes and obesity, it's so, in clinical trials, you can put people on diets for like 3 months, but in practicality, like keeping people on diets for years to reduce cancer risk and, or recurrence is much more difficult. So I always wonder, like, do you think the diet is practical, or should we be just looking at like the molecular targets that change related to the diet and then developing pharmaceutical agents to target those?
Well, I'm hopeful that this is actually going to be more sustainable. And the reason I say that, there was a study from Pam Taub and Sachin Panda when they did this in a small number of pre-diabetics. And as you said, when they're on the study, everything's great and everything changes in the right direction. But they followed up with these people after the study ended. And even a year later, after the study ended, the participants were still doing some form of time-restricted eating. So it sort of suggests that, they actually felt better when they were doing it, and it was easy for them to maintain. So I think, unlike diets, which, you're right, diets, people never stick to diets. This, I think, is something that perhaps you could do, because you're not changing what you eat. You can still eat the same food. All you're doing is changing the window in which you eat it. And I think a behavioral modification like that is just getting used to eating your evening meal a little bit earlier is probably more sustainable than actually having to change what you eat.
Interesting. Yeah. I mean, my other, I guess, is sort of just like anecdotally, but I have some people who do this sort of intermittently. So I wonder if there's a benefit to that too. Like they'll do it for 3 months and then they sort of stop and then they'll start again. So I wonder, I don't know that anybody's ever looked at kind of longer term, if that's beneficial, or if you want to do all the goodness after,
Yeah, I don't know. I think it's going to depend on how long they stop. In some of the early studies that Sachin Panda did, they actually tested that to see, do you need to do it every day? And so it was a mouse study, but basically they gave the mice the weekend off, because they figured, well, people on the weekend, they're going to go out and they're going to go to a bar or whatever. So on the weekends, the mice just ate whatever they wanted. And so it was a 5-day on, 2-day off. and the benefits were maintained. So the short period, a couple of days, didn't interfere with the, the positive effects. Obviously, if you leave that for 2 weeks, 3 months, whatever, who knows? Yes, I mean, you're probably going to lose those effects. The TRF in our hands, it doesn't happen immediately. For the mice to get, fully back to their normal metabolism, like a lean animal, it took at least 8 weeks. So, maybe, if people went off, maybe, to go the other direction may take a while as well. I don't know. We haven't, tried that yet. We have tried doing the time restricted feeding in a yo-yo diet model. So people, they diet, which is good, and then they fall off the wagon and they go back up again. And so we actually did this. We made the mice obese, we put them on a diet, we got them back to normal weight again, and then we put them back on the high-fat diets with or without the time restricted feeding, and it actually helped to prevent the weight regain in a yo-yo diet kind of paradigm.
Interesting. Thank you.
And then we have a question from Erin Giles.
Yeah, that was a great presentation. I had a question about the immune system. If you looked at, I'm assuming these mice were Black 6, and so they should have a functional immune system. Did you look at any immune markers, either in the mammary gland or in the tumors, and did the TRF affect those?
Yeah, I mean, we all of these are done in immune competent animals, because obviously, the problem with xenograft studies, using human breast cancer cell lines, there's no immune system, so it completely eliminates that whole component. So these are all in intact mice. And in these studies, we haven't done that, but, we published a few years ago a study looking at omega-3 fish oil fatty acids. And in that, we did look at inflammation as well as the hyperinsulinemia. And the interesting thing was, if you have a mouse on a high-fat diet, you increased inflammation in the adipose tissue. If you supplement with fish oil that's rich in omega-3s, the inflammation goes down in the adipose tissue, and that was known. But if the adipose tissue has a tumor in it, there is no effect on inflammation. That the sort of the positive effect of reducing inflammation doesn't happen when there's a tumor there. The tumor seems to override any of the positive anti-inflammatory effects of a fish oil diet. We also did a study using etanercept, because one of the major cytokines that went up in our mice was TNF. So when we treated mice with etanercept, it had no effect on tumor growth. So in our hands, we don't think it's the inflammation that's actually affecting the tumor growth directly.
Okay, but you might then predict that in the polyoma middle T, where they don't have tumors yet, it could play a role, but you think the insulin is the huge driver there then, obviously.
Yeah, well, so there is that delay in the tumor initiation. So, these are mice that they're put on a high-fat diet at the age of, 8 weeks. So they're not obese when we start the study, but by the end of the study, they are obese. And that certainly does accelerate when these tumors form. And yeah, I think it's probably more the insulin rather than any inflammation there.
Yeah, no, that's great. Thank you.